It's a pleasure. So, what I'm going to do is take you through a little bit of a journey, which is partly a personal journey, but also a research journey. And I'm going to bookend this talk with a man who I saw who was pretty typical case of someone who's very disabled with pain, and talk through his story in terms of understanding this approach. Just before I start this talk, of course, I want to acknowledge that I'm linked to a large group of people, both here in Australia and internationally, and I'll acknowledge them at the end. So a lot of this work is that I'll present is not just our work, but it's it's a work of a large body of people and also other research groups around the world. So why is that not moving? Oh, here we go. So this is Jamie's story.
My name's Jamie Eaton.
Yep.
From New
You got
Zealand.
it?
Married with 3 boys. Come back at work full time, and I've got a few hobbies. Lifting weights and boxing. I got it from doing weights, so it was self-inflicted. I had a discectomy between L5 and S1. I had a nerve sleeve injection. I was a week out of having a fusion, so I was pretty bad. I went for a second opinion, went to a physiologist, went to a physio, 2 other physios, sorry, and they all said, look, if the neurosurgeon, if he said you need a fusion, you need a fusion. And the neurosurgeon had told me that I'll never run again and stuff like this, just stuff that I didn't want to hear. From pretty early on, I started on quite a lot of drugs. Wasn't sleeping well. Having Lyrica, Tramal, sometimes Valium and Meloxicam and anti-inflammatory. All I was doing is laying around because I didn't know what else to do. I'm dealing with 3 kids and not being able to lift up my 2-year-old and my wife, like putting her through, because I'm not moving. I'm laying on the ground. That's all I'm doing. I'm getting up for 20 minutes at the most. And, I'm just in a real bad state.
So that's Jamie's story, and sadly, that's a story that's way too common. If you kind of reflect on Jamie's healthcare journey over the period of time before I saw him, he'd had a lot of different therapies. He'd seen 4 different physiotherapists, had been given various passive interventions, core exercises, postural advice, which is pretty typical for a person with back pain. He'd had 2 MRI scans. He'd been given a cocktail of drugs of opioid and Valium and non-steroid anti-inflammatories, Lyrica, pregabalin. For his pain, he'd had 2 epidural injections and 2 facet joint injections. He'd then gone on to see an exercise physiologist who had told him to reinforce the message that you had to protect your back and work your core, and he had to hold his posture and be careful when you bend, which again is very typical in our health environment around managing back pain. He had had a discectomy, laminectomy, and when all of this had failed, all this treatment, he was then told that because he had degenerate disc at his L5S1, he needed to have a fusion. And now, if you just think about all this treatment, where did it leave Jamie? And he's pretty clear in that interview that he was disabled, he was not working, he was out of control. He was using avoidance and protection as his strategies in managing his pain. He was lying around. He'd been advised to avoid physical activity, to avoid bending his back, avoid lifting. And so he was doing that because that's what he had been told. At the point where we saw him, he was depressed, he was frightened, I had lost hope. And really had come to the point where he wanted me to just reinforce that surgery was his best option for his care. But he was frightened to do it because he had talked to others who had gone through that path and had not responded well. If you think about the costs of this kind of care, it's really expensive. And, estimated costs in Australia are huge. And, the costs of lumbar fusion, again, massive, let alone the time off work. And let alone the kind of negative impact that this whole process has on family and friends and loved ones. So we look at Jamie's MRI report. It reads as you might see many MRI reports. Words like degeneration, disc bulges, annular fissures, joint arthropathy, that's L5S1, 4-5, L5S1, narrowing, bulging, degeneration, granulation around the L1 nerve root. And when I asked Jamie what he thought about this report, he said it terrified him. He said it feels like it. I'm a 40-year-old guy, and it feels like I've got a back of an 80-year-old. And he used exercise as his strategy of managing his health, and the very thing that he loved had been robbed from him. And so this idea of his next phase of treatment would be to fuse that L5S1 vertebra was his kind of next step. Now, if we look at the current model of care for back pain, it's typically a step care model, where in the early phase, in the primary care space, typical treatments are a combination of pharmacology, education, and education can be very often not aligned to guidelines and often reinforcing many of the myths that we know are prevalent in society. Often involves passive therapies like manual therapy, manipulative therapy, some form of exercise, although often the exercise is tending to be directed towards guarding and protecting the back. So stabilizing exercise are very commonly prescribed for people with back pain. The problem is that we know that about 30% of people with back pain are not responsive to that primary care intervention. And we know that what predicts those people are things that are non-structural, things like fear of pain, avoidance of movement, activity of work, emotional distress. But in spite of the fact that those are the predictors of what leave people vulnerable, we tend to then end up taking those distressed and vulnerable people and imaging their backs and telling them that their backs are damaged and arthritic and degenerate. And we stick needles in their backs and we drug them with drugs that make people depressed, like opioids, which are not effective, that have a negative impact on people's general and psychological health. And then when that doesn't work, we start doing things like surgical interventions to attempt to fix those findings on a scan, which we know are incredibly prevalent in pain-free populations. And the problem with that is when that whole process fails, then they end up in this multi-disc care model of kind of failed back pain. What we do know is when we look at the evidence around that care space, that secondary care space, and we know certainly across many countries in the world, we have an opioid epidemic where we are drugging people who are in pain and who are distressed, and it's not working and leaving them highly vulnerable, is that this care is often seen as low value. So low value care is care that is risky, has little benefits, and is often pretty expensive. What we don't have is a good in-between space of people who are failing primary care interventions to deliver care that is directed at their risk, care that is directed at the things that predict them not getting better, like being frightened, like being avoidant, like being distressed, like the prevalence of other health comorbidities that we know are linked to pain. And so really we are fundamentally failing this group of people in our care system. And that's why we start seeing a whole lot of papers that have emerged in the Lancet series in 2018. It's probably the kind of one of the summary papers that really put this out there, that we are actually potentially hurting a lot of people with back pain by providing low value care to them. We're over scanning people who don't have an indication for scan. We're telling them they're damaged based on normal MRI findings that are prevalent in people who don't have pain, and we're making them more disabled and driving them towards more low value care. That often our physical therapies are driven around passive therapies, reinforcing erroneous beliefs, driving more protective guarding through teaching people to brace their core and tense their abs and hold their postures. We're drugging people with drugs that are no better than placebo or non-threatening or dangerous drugs, and the long-term, the risks of those drugs are significant in terms of negative health impact. We're sticking needles in people that offer at best short-term pain relief, but very often just leave people out of control and more distressed. And at the end of that process, we're offering interventions like fusions that come with significant risk and are massively expensive, that have no greater efficacy than some very basic non-surgical interventions. And so that's a massive issue for our society. And if we look at the kind of pattern over the last 15 years, we see that the disability burden of back pain, this is the last 25 years, the disability burden of back pain has actually escalated. That with all this money we're spending on back pain, we don't see a reduction in the disability burden. We've seen it increase up to 50%. It's a massive problem we've got. You can see on the right, this is just a case of a man who I'd seen who brought in literally, 8 or 9 scans, that he'd been scanned and scanned and scanned and scanned, looking for the structure that was causing his pain. And at the end of the journey, he'd had his entire spine fused. And at this point, he was completely disabled, distressed, depressed, with huge amount of drugs that were ineffective to manage his pain, and at a point of really wondering what his life was worth. So when we start looking at the epidemiology of back pain, we see that it is the biggest burden, ironically, of years lived with disability, of any health problem. We have created a monstrous problem of the way we've understand and cared for back pain. So this is reflected in these huge increase in costs for managing back pain. And it's, of course, now not just back pain, it's neck pain, it's hip pain, it's knee pain, shoulder pain, that kind of fit in this whole space, that we are spending more and more money trying to chop this problem, often driven out of healthcare practitioner and patient societal beliefs, and the fact that we image the body and find stuff that doesn't look perfect and then try to fix it with crude surgical techniques. So we scale back then and go, well, what do people believe about back pain, and what do healthcare practitioners believe about back pain? And there's a lot of evidence emerging now that that as a society we have some very negative beliefs about back pain. That this view that backs are easy to harm and hard to heal, that back pain is caused by injury and damage, that the spine is vulnerable and needs to be protected. And so if that's the belief that people in society have, and healthcare practitioners are caught up in this space as well, then the first thing you want to do if you have pain is think, my God, I'm in pain. I must be damaged, therefore I need a scan. And the problem we've got with scanning is that we find stuff in the majority of people. So we start naming back pain things like degenerative disc disease as a diagnostic label, which frightens people. That is a signal that people should protect their body. And then we put these signs up like, don't bend your back when you lift, guard your back, brace your core, sit tall, don't slouch. We have these messages around the body that the body is vulnerable and needs to be protected. And so these things drive behaviors. Now, the crazy thing is, and look, I've been part of this space. If I look at my undergraduate training and my early years as a physiotherapist, I held these very same beliefs. I've published around them in my early research career. But the work we've been involved in and other people's research has shown that there's very little causal evidence for these beliefs. And this reflects the view of society and healthcare practitioners, which of course sets the scene for a catastrophe in terms of our understanding and managing and caring for people with back pain. So the first thing we have to be very clear about when dealing with back pain is that we must always screen for serious pathology. There is a small but very important group of people who we need to care for, um, uh, and that group has to be screened. So what are we talking here? Malignancies, fractures, infections, inflammatory disorders would fit in that space. And we need to be very aware that that's a group of people we must identify. We also know that there is a small group of people who will have some specific pathology that is correlated with their pain, something like a just prolapse with radiculopathy, acute radiculopathy, plus or minus neurological deficits would fit within that space. Stress fractures would fit within that space. The problem we've got, though, is that we've got this very large undiagnosed group. Now, what has happened effectively since the advent of MRI scan, what used to be called undiagnosed back pain is now kind of put in this basket where we start calling them findings on a scan: degenerative disc disease, disc bulges, fissures, facet joint arthritis. So we've kind of put that group in a diagnostic basket. And the problem with that is that they aren't really valid diagnoses of back pain, because we know that those findings don't correlate that well with levels of pain and disability. So we start thinking about what might underpin back pain. We have to go back, scale back and go, well, what's the nature of pain? How does pain work in our body? And essentially, a modern understanding of pain is that it provides a protective function that's determined by implicit evaluation that the body's in danger and needs to be protected. So this is influenced by heaps of things like our context, our culture, the meaning of the pain, our awareness of a pain, our previous history of pain, our parental beliefs around pain, our personal beliefs around pain, our social setting. All of these things will influence how we respond to pain. And these two images are kind of like a very extreme view of that. You may have seen the image of a man who'd had a nail put through his boot, and this was published as a letter in the British Journal of Medicine in the mid-90s of a man who was on a building site, got a nail through his boot, was in pain and highly distressed, went to emergency. They gave him fentanyl to sedate him, took the nail out and the boot off, but the nail actually just went between his toes. So there was actually no tissue damage, and yet this man was highly distressed and reporting pain. You see the other man who has skewers through his throat, where there is clearly tissue damage, but you don't see any distress on his face. In fact, he's willingly allowed for these skewers to be punctured through his body, and clearly this comes with significant risk. And again, this highlights the role of culture, belief, context, social environment in terms of how we respond to something that may or may not be threatening. And it highlights again this idea that we can't, nociception and pain don't sit in a linear relationship always, that we can have nociception in the absence of pain and potentially pain in the absence of tissue damage. What this highlights is the complexity of our nervous system, and that is the pain network can be activated, or the pain network can activate a number of levels. So we have nociceptors in the periphery, which are danger receptors that may be activated in the presence of tissue injury, tissue strain, trauma, fractures, etc. But we also are governed by things like our beliefs, our attitudes, our attention, our coping, our expectations, but massively by our emotional status. The amygdala processes information around fear, anxiety, associations, and mood, implicit attitudes and behavioral responses to pain. And this part of the brain is sculpted from an early age. And we know now from a number of studies that early life trauma can massively predispose people to ongoing pain or nociception, ongoing pain or pain chronicity in later stages in life. And so this whole complex of our cognitions or beliefs, attitudes, thoughts, our emotions, as well as what's happening in our periphery, is this really amazingly complex system that influences whether we perceive pain or not in different times of our life. And this highlights that we have different kinds of pain. We have what we most typically understood as nociceptive pain that might be associated with tissue trauma or tissue damage. We have inflammatory pain, which is also nociceptive, which could be post-injury, but also linked to some kind of inflammatory disorder. But then we have other kinds of pain states like nociplastic pain, where there is no tissue damage. And this is often the case. You might see someone who's had a headache. Now, you could have a headache from a head injury, a trauma. You can have a headache from some kind of chemical sensitization, or you could have a headache because you're stressed and tired and run down and got a lot happening in your life where there is no tissue damage. And the same thing for back pain. You can have, we've seen this in a number of studies now, that pain can be, in the back can be linked to trauma, but it can also emerge at a time of stress, of ongoing distress or changes in mood that can leave the person at risk. And this is where the nervous system, we know, can fluctuate around its levels of sensitivity. We also have neuropathic pain, which is more specifically related to nerve injury. That doesn't so much relate to back pain, but it certainly may relate to post-surgical management of something like sciatica, if there's been some nerve damage. Now, when pain persists, and I think we often think of acute back pain as nociceptive, but I think that's problematic, and that we know that a lot of back pain is not triggered by a trauma or an injury. And we just published a paper just this year looking at people present to emergency departments with non-trauma pain, and 50% of this is back pain. These are people with no trauma presenting to ED with 7 out of 10 pain, highly distressed with a lot of pain, but they've had no injury. So they would be sitting in that nociplastic pain basket. There's another group that would fit with people who say maybe nociplastic pain or a mixed pain picture. People who may have had an injury but then have got ongoing pain, and that pain can then shift from nociceptive to, say, a mixed pain picture. That pain that persists after tissue repair is persistent pain, or it may be a combination of factors linked to changes in tissue, say modic changes in the spine, which is an inflammatory process. So there's some nociceptive component, but then centrally amplified pain linked to the person's level of mood, distress, and other factors around lifestyle. So if we look at the contemporary understanding of pain, we know there are genetic factors. We know there are times in our life where we're more vulnerable to back pain. We know that back pain very rarely presents before the age of 10. That pain rapidly increases, the reporting of back pain rapidly increases during adolescence, and then it kind of sets its stage in early adulthood through towards the rest of life. We know that how you respond to pain is influenced by your beliefs, and there's lots of evidence emerging around that now, but also to your emotional response to pain, your social environment, your way you physically engage with your body, your lifestyle, and other health comorbidities. Now, the combination of these factors, which we often see as modifiable risk factors, influence changes in structure, changes in the motor system, and changes through the nervous system that can leave people either vulnerable or resilient to ongoing pain and disability. So if you take an example of resilience, you might have someone who develops pain, has a positive mindset, has got a healthy emotional in a healthy emotional state, has supportive social environment, involved in good physical levels of physical activity, have a healthy lifestyle and minimal health comorbidities, chances are that person will never seek care, will not end up with disabling pain. But if you have someone who has a negative affect, they may have some very negative beliefs about back pain, they may be emotionally vulnerable, they may have a difficult social work setting, they may be inactive or have bouts of overactivity. They may have poor sleep. They may be overweight and have other health comorbidities. Those people are at very high risk of developing ongoing pain and disability. And so when we look at something like back pain, it's not just the experience, but it's the combination of all these factors that influence changes on the motor system, on structure, and within the nervous system that can set people down a pathway. Understanding these factors is incredibly important, because the view that we would take is not to target your care at the structure, but to the drivers of change within the system. And that really fits with our model of understanding and managing pain. So when we start looking at what predicts disabling back pain, there's growing and emerging evidence that that someone who develops acute back pain is at risk if a number of factors emerge. They're at risk if they have poor socioeconomic environment. They're at risk if their pain is more severe. They're at risk if they have greater social stress. So these are things that we need to be screening first and foremost when we see someone who presents to us. They're also at risk if they develop a negative mindset around their pain. If they have a belief that back pain means I'm damaged, it's caused by an injury, that it's going to leave me disabled, that it may never get better, and there's nothing I can do to control it or cure it. And these are often, sadly, the messages that healthcare practitioners feed patients, that create a mindset that is negative. The problem with this mindset, it often leads to negative emotional responses. It can create fear, that back pain should be feared, and emotional distress. When we start losing our ability to do stuff in life that we love, often our mood is impacted. And so we often see that this is coupled with negative or passive coping behaviors around rest, protecting the body, avoiding activity, work, passive therapies that might involve physical therapies, but massage, passive hands-on approaches, or electrotherapy, or it could be pharmacology, injections, or surgery. So these factors, if they emerge early in life, are predictive of ongoing pain and severe pain 5 and 7 years later. And these are things that we have a direct role in influencing in terms of the way we care for people in pain. We influence the mindset of our patients. We influence their emotional responses to their pain, and we influence their coping behaviors. These become the targets of our care. So we look at a common sense response to a lot of the negative illness information. And so for Jamie, he said, these were all the messages that he told me he'd been told. He'd been told his disc was stuffed. He'd been told to rest if it hurts. He'd been told he could never run again or lift weights again. He had been told to avoid bending, to sit tall, to brace his core, to guard his back. He'd been told he shouldn't work with his pain. He'd been told he needed drugs to manage his pain. And when all that failed, he'd been told he needed a fusion. Now, if you look at all that health information, that feeds a negative mindset. That tells him that your back is vulnerable, it needs to be protected, it needs to be fixed. If we look at the consequences of that information, that made Jamie frightened. He was fearful of damaging his back. He's had this belief that pain meant he was doing more harm. He had developed catastrophic thoughts around there's nothing that I can do to get better. Could be in with this for life. I'll never go back to being active. Now, these weren't things that he dreamt up himself. These were things he had been told. He had developed very low self-efficacy. He had very little confidence in his ability to move, to work, to play with his kids, to exercise. He had very little insight on what he could do to manage his pain. He had developed a lot of avoidance and passive coping behaviors because he had not been offered anything else. And the consequence of all of this is he was really distressed. He was highly anxious, and his mood was very low. He wasn't sleeping. And so you see how this combination of negative health information drives these behaviors and negative emotional responses, which we know are key drivers of pain chronicity and severity. So we look at common responses to pain. We often use avoidance as a strategy to control pain. But the problem with avoidance is it's appropriate when you've got someone who has tissue damage, like a fracture. But avoidance should only last for a very brief period of time. In Jamie's case, he hurt his back lifting, but it was many months later that he was still disabled and lying in bed, well beyond any tissue healing. time it occurred. And so the problem with avoidance is we start seeing that it's like a wrecking ball that goes through someone's life, and we generalize it. And as we generalize it, we become more disabled. This is a quote from Sam Bonsley's paper in JSPT in 2018 of a patient. I thought maybe if I stopped doing everything, it might get better, because you're scared of moving. It's like common sense, where you don't do anything. But then I got weaker and weaker until I was at the point I couldn't even do the dishes. I couldn't bend, I couldn't lift. And I was thinking, oh my God, I can't do anything without pain. Now, that was a 51-year-old lady with back pain, but that was very much Jamie's experience, when he started avoiding all the things in life that gave him meaning. And when that happens, we end up being distressed and depressed. We start looking at the relationship between pain and movement. We've historically been fed this line that when you've got back pain, your back's unstable and you need to work your stabilizing muscles, you should keep your posture, guard your back. Well, we now know that people with back pain already do that. We look at the systematic reviews of people with back pain, they move slower and stiffer. They are more co-contracted, and they can't relax their muscles like their back, like their multifidus and their abdominal wall muscles. They engage in breath holding and bracing. So we see this a bit like clenching your fist around a sore wrist. They're clenching their back and abdominal wall muscles when they go to bend, and they're guarded in the way they do it. And often our rehabilitation programs further reinforce the very things that people do to protect and guard their back. We know that backs need movement for their health. It's important to be strong, but it's not helpful to be constantly guarded and co-contracted. We know that lifestyle behaviors are important, of activity avoidance, factors like abdominal obesity. There's growing evidence around the role of particularly abdominal obesity in terms of increased systemic inflammation in the body. That is a risk factor in terms of lower pain sensitivity, or increased pain sensitivity, inflammatory changes around structures like the disc and end plate, like motor changes. So these are also very important factors. And sleep is the other huge factor we know is linked to a whole bunch of musculoskeletal pain disorders, and in this context, back pain. So the net consequence of this whole process of negative health information, passive coping, avoidance behavior, protective guarding, is that it often leaves people stuck, where they try doing the stuff that they've been told to do and by various healthcare practitioners, and the more they try, the more stuck they get. And this lovely paper of Sam Bonsley's describing the lives of people with chronic pain as getting like life on pause, where they see their wellness is suspended, their sense of self is suspended. There's this negative psychological impact, and they have this suspended sense of future. They can't move on with their lives because they don't know how to go about doing it. They have this uncertain sense of their trajectory. So the question that we have as healthcare practitioners, and certainly as researchers, is how do we get someone like Jamie, who presents a week out from having a lumbar fusion? How do we take someone who's lying in bed, who's frightened, who's got a negative mindset around their pain, who's guarded and protective? How do we help them jump that ravine to get back to living again, to get back to play with the kids, back to work, lifting weights, running? And is it even possible? And I think in our health landscape, we've almost given up believing that can be possible a lot of the time, that we're just teaching people to accept that they are disabled and that they have pain, and then we drug them to try and help them with their distress. And so that's been a huge part of our interest, is to say, what can we do to take someone from one side of that equation to the other? And we kind of see this approach as bridging a gap. Now, just to be clear, this is not the way, it's a way, and it's a way in which we've integrated a lot of work around behavioral understanding of pain and pain neuroscience with physical therapy practice as a means of trying to bridge that gap. Now, if we look at the guidelines for back pain, and these are the NICE guidelines that were published a year or two ago, then of course we need to, for all people with back pain, as I've said, screen for red flags. And so, yeah, Jamie had been screened for red flags. But when we've screened for red flags or serious pathology, the next thing we need to do is to screen them for risk factors of non-recovery. So we talked about earlier that the risk factors for non-recovery are things like fear of pain, low mood, issues around work, seeking litigation. Now, for Jamie, he would have screened high on some of these risk factors, not all of them, but some of them that would have put him at risk. He never had screening once in his whole health journey up until the time I saw him. The next thing the guidelines suggest is that we should provide evidence-informed information and effective self-management. Well, Jamie had a lot of non-evidence-based information. He had erroneous beliefs around back pain. He'd been told all kinds of rubbish that left him distressed and frightened. The guidelines say that we need to, he had no self-management strategies. He'd been given core exercises that left him more guarded and co-contracted. The guidelines next suggest that if we've got someone who's non-responded and who's distressed, then we have to integrate physical and psychological approaches to care for these people. Jamie had none of that. He'd had various physical approaches, medication and interventions that were non-evidence-based. The guidelines say don't operate on people with back pain. He only had back pain. He'd had epidurals and decompressions and suggested to have a spinal fusion. These aren't even in the guidelines. And so what you see here is that often care for back pain has nothing to do with evidence. It's got everything to do with healthcare practitioner beliefs and vested interests in terms of the way we're caring for people. So what does a cognitive functional approach look like? Well, we see there are three key components that are critical in helping people like Jamie. The first is helping them to make sense of their pain, to give them an understanding that pain is not just about tissue damage and injury. Pain is a complex process of links to beliefs, emotions, and behaviors that can influence the way that you interpret and cope with your pain. The second component is building confidence with movement, getting people back to engage in things that previously that are frightening, they've avoided, or that are painful. And the third component is targeting healthy lifestyle, getting people sleeping well, getting them active, helping them manage their stress, managing their diet. And these are the three key underpinnings factors in that approach. Now, to take someone who's frightened and has failed lots of care through that journey is a really tough thing. And we see ourselves as coaches, not as treaters in that journey. But you need to have a very strong, trusted relationship with your patient. And so developing excellent communication skills is a critical part of this journey. So we look at Jamie's situation. He reported back pain. That was his questionnaire he filled in. He had pain in the back, quite widespread around the back and the buttocks. His screening tool, this is the Orebro screening tool. His pain was 9 out of 10. This is the time I saw him. He was disabled. He wasn't sleeping. He was very high on stress anxiety, high on depressed mood. He had very negative beliefs that his pain, of course, would become persistent. He didn't believe he could go back to work. He was fearful and avoidant of movement. So the first point, we spent an hour with him. And part of this hour was spent to take his history, to listen to his story. And we take a view that the patient leads this process. We're interested in his story, his pain beliefs, his behavioral responses, his levels of confidence, how this pain was emotionally impacting on him and his mood, his worry, how that was impacting on his social factors, his family, his work, interested in his lifestyle, his sleep, his activity levels, his diet, what his goals were, what his expectations were, what his values were, and of course screening for other things around his general health and to make sure that we're not dealing with anything in terms of serious pathology. So that might take up to 25 to 30 minutes to just sit down and listen to his story. And of course that's very much underpinned by a motivational approach which we utilize. The second phase, the assessment, is around behavioural experiments. So we're interested in the things that he couldn't do. So he had a lot of discomfort sitting. He was terrified of bending. He completely avoided lifting. And so we would observe the behaviour around sitting, bending, lifting for Jamie. They were his key things, and to look at them. And we observe for things like safety behaviours, protective guarding, breath holding, propping the hand, as well as pain responses. And Jamie reported pain immediately with any attempt to flex his back. He had high levels of protective muscle guarding. We then use behavioural experiments to disconfirm someone's beliefs. So we explore their levels of fear and pain expectation. So for someone like Jamie, that would be forward bending. We ensure the person's safe. We focus on teaching them to relax their body, so to reduce that sympathetic, protective fight-flight response, to take them more into a parasympathetic relaxation response. We might do that in a graded way to reduce the protective guarding and safety behaviours. We look at normalising their sense of their body, so we might use mirrors or hands-on feedback. And then we take them back into the very thing that they thought they couldn't do. And often we grade this up. So for Jamie, his fear was to bend. For a start, we teach him to do diaphragm breathing. We might teach him to do posterior tilt, bring a knee to the chest, start to flex and sitting, then to go to bending, and then back to the thing that he thought he couldn't do. And at the end of the first session, he was found that when he relaxed and gained confidence to bend, actually he had less pain when he didn't guard and protect and when he flexed his back. And in doing that, that violated his beliefs. So he was thinking that bending was dangerous and was going to damage him. But in fact, to relax and bend reduced his pain. That reinforced, it helped break down this negative mindset around his back is vulnerable and needs to be protected. And so we deliberately use these experiments to violate someone's expectations and to build their self-efficacy, that the back can be trusted and used and moved in a normal way. We use a lot of reflective questioning in this process because it's much harder to argue with your own information than it is to argue with advice. And so we would say to someone like Jamie, so Jamie, when you relax your back and bend it, how does it feel? And he goes, well, it actually feels better. What does that tell you? Well, it tells me it's safe to bend. So what does that make you think about your back and the way you've managed it? Well, it makes me think I've probably been hurting myself. So I'm not telling Jamie this. He's finding this out for himself. So we look at Jamie's pain schema. He had this mindset that his back was damaged. It was caused by wear and tear and injury. He was disabled. He needed a fusion. He used avoidance and protective guarding. He was highly distressed, and it didn't work for him. And so taking him away from this process of understanding that actually his pain presentation was not just about his structure. It was related to his lifestyle. He was not moving. He was not sleeping. He was guarding, he was protecting, he was off work, he was stressed, he was lying around in bed. It affected his social situation. He had these negative beliefs around his body. He was distressed, he was sensitized. And yet, sure, he didn't have a perfect looking spine, but those other factors seemed to be the most dominant in his presentation, and they were the things that we could influence. So at the end of that process, we'd sit down with Jamie and say, look, Jamie, you hurt your back. You've been given some pretty scary advice around your back, that your back's damaged, and it's made you frightened. Your natural response to that is to tense up, protect your back, and avoid stuff. But that's left you vulnerable, guarded, sensitized, depressed, and it's linked you back into pain. And all of those factors now are feeding a vicious cycle. So a lot of those things we can change. We can help you learn to relax. We can help you learn to move. We can help you, give you a different mindset around your pain. And so through this process, we help develop a new mindset or pain schema. We dispel myths, being careful not to contradict people's ingrained beliefs, but to just give them direction towards other patient stories who've, like Jamie, who've got out of trouble. We explore different ways of responding to pain around movement, relaxation, engagement, social activity, work, etc. And we target their goals. So whatever the things that they value are the things that we target in their care. So these are very different health messages than what Jamie had been told. That movement and physical activity is actually really important for the health of your back. If it hurts, relax, breathe and move normally. Pain doesn't mean harm in your situation. Backs can be trusted. They love to bend. It's important that you get good sleep and regular physical activity. We've got to get you back to work. That these findings, even though they may not look great, are very common with people even without back pain. So this process then builds someone's confidence to move. That idea of getting people back to engaging in life and the things they value, and then generalizing this learning into valued activity. So reducing the sense of threat, building confidence, getting people conditioned, because he was very deconditioned, and then back doing the stuff that they love. So for Jamie, it was playing with his kids, it was lifting weights, it was working out in the garden and getting back to work. We also target lifestyle factors around physical activity. We see it as a minimum dose. Really worked on his sleep habits and relaxation techniques. Dietary factors weren't his issue. So what evidence is there that this approach might be effective for people with ongoing back pain? This was a trial that was conducted in Norway with Kjartan Fersum was the lead author in this trial. And this compared a CFT approach to a more traditional manual therapy and exercise approach, which is pretty typically delivered for people with back pain. These people had moderate levels, low to moderate levels of disability, but pain around 10 years of duration. What you see on this graph is in the blue is the reduction in levels of pain of disability in the CFT arm that was significantly greater than in the manual therapy arm. There was the same finding for reductions in pain intensity, both at a 3-month follow-up and 12 months later. And I should just clarify that that intervention involved 7 sessions over about 12 weeks. A 3-year follow-up paper was published this year. Came under some criticism because there was a large dropout. This was accounted for in the statistical analysis, but of course, large dropouts do create some uncertainty in terms of outcome. But in saying that, while adjusted for these losses in terms of dropout, there was a 3 years later, there was a significant reduction in the levels of disability still in the CFT arm. Now that interests us because it suggests that there may be some ongoing behavioural change for these people down the track. It was also observed a reduction in pain episodes, an improvement, a reduction in their fear, an improvement in their mood, less need for ongoing treatment, and less time off work over previous 3 months. And people liked it. They reported satisfaction rates were really high at 12 months. People felt like they were back in control of their life and doing the stuff that they loved if they benefited. You might be familiar with Mary O'Keefe's trial. This was with Karen O'Sullivan up in Ireland. And this was a really interesting trial that compared CFT, an individualized approach, as I've described, to group education and exercise. And this trial was again conducted in people with more disabling back pain, with often multiple pain areas and other pain comorbidities. So the kind of patients that are often are taken out of clinical trials because they make our trials difficult. So there are a lot of people included who had psychological comorbidities in this trial because we were interested in whether we could help these people. So the interesting finding in this trial is that the individualized arm, both arms of the study showed improvement, but the individualized arm in blue, you can see there, showed significantly greater reductions in disability at 12 months, so 6 and 12 months down the track, compared to the group exercise and education. Interestingly, there was no significant difference in terms of levels of pain. There were also significant reductions in terms of, improvements in pain self-efficacy, pain coping, and reductions in the Orebro questionnaire in the CFT group. So that's an error in my slide. Now we start thinking, what might be happening with this intervention? Well, we understand that pain's influenced by beliefs, behaviors, and attitudes and responses and emotions. We directly target beliefs to try and build a positive mindset. We try to reduce people's fear through exposure to feared activities, building confidence back in their body. We target the system through relaxation techniques, better sleep, and increased physical activity. So we try and target the system through all angles. And that may be one of the factors that underpins this process. We don't know. We have some evidence that people going through, unpublished at this stage, that people going through this intervention showed reductions in terms of tissue sensitivity around pressure pain thresholds. So we're seeing biomarkers of change, as well as changes in people's beliefs and behaviours and emotional responses. A qualitative study was conducted a few years ago that looked at people who responded and didn't respond to this intervention. And the story that we saw was that those who responded accepted that pain is related to biopsychosocial factors. It's not just about structure. That these people reported achieving independence. They felt like they were back in control of their pain and living again. So when that happened, people felt like they responded well to the intervention. And that's comforting, because they are the key targets of the intervention. That was reliant on a very strong therapeutic alliance. If there wasn't a strong relationship between the therapist and the patient, then often this process didn't occur. People who didn't respond to the intervention, and of course there are always non-responders, these people tended to have more fixed biomedical beliefs. They thought that their structure was damaged and it needed to be fixed. There may be a need for surgery. They didn't report any control of their pain, and their functional capacity was still very limited. There was an in-between group of people who sort of understood that they had a biopsychosocial nature of their pain, but they lacked independence and they weren't able to control their pain. So we know that this approach is not helping everybody. We know that we are still not reaching a number of people here, and we're really interested in our ongoing research to target those patients who are particularly vulnerable. If we look at Jamie's care, we would say that's high-value care. He had 8 sessions over about 6 months that took him through this process. He also had some support from a psychologist around his mood and his levels of distress. He got off all his medication. He didn't end up having a fusion. He got back to work, playing with his kids, boxing, running, lifting weights again. And that's a pretty cheap intervention if you consider the enormous cost of what he had had previously that had left him completely disabled. And we're particularly interested in our ongoing research now to look at cost evaluation of this kind of model of care compared to other more contemporary or usual care models in our health system. So you'll hear now Jamie telling his story after going through this process.
A week out of having that fusion, I found a physio. He was the last resort, and I was hoping that he'll say, "You need a fusion," because I just want it all to stop. And then when he told me that he reckons he could help me, that was pretty full on. He said, "You've got this degeneration, but so is most of the population." I told him, I said, "Look, I'm doing everything right. I'm putting the roll behind my back when I'm driving." He said, "What for?" I said, "Well, because everyone says to do that, And he said, "Throw it away." A week out of having that fusion, I found it. Think, why is my mind? I can't do that. I've been laying down all day.
Sorry.
And to ride an exercise bike as well. And I was thinking, what? I can't do that. I've been laying down all day. I can't ride a bike. You think, why is my mind working against me? But it's just how I trained it to work for that 6 months or so. I'd work myself into that, and I had to get out of it. And it was stretching, and people are probably going to see this. And if I say meditation, they'll start rolling their eyes or something. But I did meditation. I went and I saw a psychologist as well. And that all helped me as well. Don't go onto the internet and read forums, because I think that people compete on there for who's got the worst, who's been chopped the most, or who's had the worst. It's just a nightmare. I went to a doctor and she said, she saw me move and she said, "Oh, that's good to see you're guarding your back." Now I know now, so you hear that and you think, "Oh, okay, I should be stiffening up." And that, what I know now is that everything I was doing was counterproductive to my recovery, big time. If I had known not to sit up apparently correctly, just to relax, chill out, throw the towel away from behind my back that was putting me into an unnatural position, not worry about sneezing or coughing. the neurosurgeon said I would never run again. I'm doing everything. Weights. I'm back doing weights again, and I go to boxing on the weekends as well. And to think that I'd kind of driven my mind, and to hear that, it's a lot to do with your mind. I think some people aren't really open to that. They'll take offense to that and think, oh, you think it's all in my head. Overcoming that it had a lot to do with meditation. It had a lot to do with me finding other interests, because I wasn't living. I was just existing, and badly as well. It was a real bad existence. And now I can do everything. I'm throwing the kids around, back hanging out with friends, going to work, which going back to work was really important. That helped me heaps. Just living.
So that's Jamie's story. And of course, that's a great story, and not everyone's outcome is as wonderful as Jamie's. But what it highlights is Jamie talks a lot about a change in mindset, of building confidence, of relaxing the body, of engaging with movement, of getting back to work, of socializing, being with friends, all these things that are part of our mosaic of living. Interestingly, I emailed Jamie 2 years after I'd seen him, and I asked him to send me a video of him doing his exercises, and you can see him doing his exercises, and these weren't exercises I prescribed him. This is the program he worked out for himself. And I think what's lovely about that program is that it shows that Jamie is supremely confident to load his back in all directions. This is a guy now with high levels of self-efficacy around his back. He is not protecting it. He's loading it. He's challenging it. He's moving it. This is a guy who is now fearless around his back, and that has got him back to living again. And I think we start looking at things like what mediates someone to get better. It's things like self-efficacy, and so much of what we tell people and the way we care for people robs them of self-efficacy. So we look at Jamie's new mindset. He'd say, well, he understands now that his back got really sensitive because of all the stuff he was doing. He doesn't see his back as caused by damage anymore. He sees that he doesn't have to be disabled with back pain, that his prognosis is good, that he can manage it, that he doesn't have to protect, that he can relax and move, get strong, do fun stuff, get back to work, that he can be calm and fearless and have a positive view of his back, and that will positively impact his mood. And that shift in mindset, behavioral response, and emotional response to pain got him out of trouble. So we look at his his current situation. He might say, oh yeah, I get some niggles in the back, but it's no longer a problem. It doesn't stop me from doing anything. I've got to manage my mood. I've got to manage my lifestyle. I've got to manage my movement and my exercise and keep socially engaged to stay on track of that. And I think we've got to understand that we don't cure back pain. We care for back pain. We manage back pain. That back pain can emerge and re-emerge at different times in someone's life. And Jamie had an episode about 3 years after he had treatment, where he had a number of late nights. He was really tired, run down, hadn't been exercised, and then dug this massive ditch in his backyard for about 3 hours, and his back spasmed, and he freaked out. He contacted me, and I said, Jamie, what are you doing? What's your response? He goes, yeah, I've gone back to my old way. I said, what are you thinking? He's going, so I said, look, come in. I saw him once. I made him bend. I made him move. I made him relax, and he was back on track again. And so I think we have to understand that pain is not cured. It's ongoing, but we manage it through managing these different factors. And we need to be on call for people when they panic, when they have episodes, so that we don't see treatment as finished, but we see ongoing support as part of our job. So where does this leave us in terms of caring for people with back pain? Well, we must screen for serious pathology. I've had examples this year of people who have had serious stuff going on for back pain that need medical interventions. We need strong relationships with our patients to take them on a journey from disability back to living, because that's a scary process for them. I see my role as a coach. I love seeing my role as a coach, not as a treater or a fixer. And we need to work closely with other healthcare members of the healthcare team. Education and reassurance is an intervention. We need to nurture and promote a positive mindset. Fostering dependence is something that we shouldn't do, and that happens way too often in health. We need to promote that movement, activity, and developing confidence in the body is something that people can achieve. We need to manage people's stress, help them manage their stress, their mood, their sleep, their weight, and remembering that the best person to be in control of someone's back is them, not us. So there are lots of barriers for implementing this kind of model of care. It's a mind shift for us as healthcare practitioners to think of the body or the back in this way, because often we've been trained to think of it in a completely different way, and certainly I was as well. So that often reflects both the mindset of us as a therapist, but also the mindset of the patient. The mindset of the patient is they'll think we're talking crazy things when we start countering the current common beliefs around back pain. We need to be really skilled communicators around listening and understanding and motivating people and helping them to understand and reflect on their own beliefs and to shift them in a gentle way towards a more positive behaviors. This takes time, and so in time-constrained environments where we're rushing by the clock, it's very hard to provide this kind of care. We've got massive health funding constraints in Australia and other parts of the world where we overfund shitty care, low-value care, and we underfund high-value care, and that's something we need to work in the future. We know that if we work in an environment where we've got very little peer support for this approach, it can leave us feeling very isolated. It can be very hard to engage in this kind of care. We know there are heaps of biomedical roadblocks, that there's a whole health system that's engaged in keeping people sick, that's engaged in promoting unhelpful and low-value care. We have societal beliefs, we've got social media, we've got the media that are driving this idea that back should be fixed and we can drug it and needle it and chop it in a way of taking it away. We know that back pain commonly presents with comorbid health problems like depression, anxiety, stress, social distress, other health comorbid complaints like obesity, diabetes, heart disease, etc. And so we need to be managing that as a team, and that can be often a very difficult process. We have a very fragmented healthcare system where the person sees the general physician, the surgeon, the pain physician, and they often give completely contradictory messages, and we need to develop much more effective ways of co-care models. The other important point here is I've talked about back pain, but the risk factors for neck pain, hip pain, knee pain, shoulder pain all look the same, and so we don't see this as a back pain model. We see this as a pain model that we can look towards. We have resources, and this is, I don't know if you've seen this, but this is a resource that we developed, which is free online, around helping healthcare practitioners to communicate with people with back pain, because a lot of the time this is where it all goes wrong at the very beginning. I want to just finally acknowledge the wonderful group of people I work with, both at Curtin University in West Australia, national collaborators and international collaborators. I'm incredibly privileged to work with some incredibly clever, humble people with shared values around trying to improve the care of people with pain around the world. And that's part of our ongoing journey. Thanks for your time.